The treatment of Hodgkin's lymphoma in general has been a success story in that we're very capable of curing the majority of the patients with this disease, and we have good treatment options available for those patients who ultimately have the disease come back. That being said, our established standards in the relapsed refractory setting, like autologous stem cell transplant and treatments such as brentuximab vedotin and antibody drug conjugates, do offer significant benefits to patients, but unfortunately, a number of patients relapse after these treatments, and thus we need to have new options available. Checkpoint inhibitors are one key option, and now that is an important treatment in patients with Hodgkin's lymphoma, but optimizing these standards and identifying how best to use them remains a clear unmet need for patients with Hodgkin's lymphoma. KEYNOTE-204 is a large international phase 3 study in relapsed refractory classical Hodgkin's lymphoma in patients that have relapsed post-autologous stem cell transplant or are ineligible for autologous stem cell transplant. The trial compared pembrolizumab versus the standard of brentuximab vedotin in this patient population and was designed to show an improvement in progression-free survival for the experimental arm. The trial outlined a primary endpoint of progression-free survival, and the trial did meet its primary endpoint with pembrolizumab showing a statistically significant and clinically meaningful benefit for patients receiving pembrolizumab when compared to brentuximab vedotin. The median progression-free survival in the pembrolizumab arm was just over 13 months in comparison to the brentuximab arm of just around 8 months, with a hazard ratio of 0.65. This was obviously statistically significant and was consistent across every subgroup of patients that were analyzed based on age, number of prior therapies, presence of refractory disease in their disease history, or even if they were brentuximab exposed or brentuximab naive, which was the majority of the patients in the study. KEYNOTE-204 was the first randomized trial in relapsed refractory classical Hodgkin's lymphoma that had evaluated two novel treatments, the antibody drug conjugate brentuximab vedotin, as well as pembrolizumab, an anti-PD-1 antibody. Given the standard had been well established with brentuximab vedotin based on its pivotal trial now a number of years ago, this represents an important trial comparing a newer approach with a checkpoint inhibitor, pembrolizumab, in comparison, and now I think establishes pembrolizumab clearly as the preferred treatment in this patient population. That being said, these agents are both very active, and we know brentuximab has moved earlier into the disease course based on the ATHERA trial, which showed advantage for brentuximab as consolidation in patients post-autologous stem cell transplant, and as well the randomized echelon-1 study that was part of primary treatment in combination with AVD over conventional ABVD. So now we have a new standard established with pembrolizumab in this patient population. We have brentuximab established based on randomized trials earlier in the disease course, and this now gives us a clear option in the relapsed refractory setting with pembrolizumab. Pembrolizumab has been studied quite broadly across hematologic malignancies, just like any other checkpoint inhibitor, given the biologic rationale, the safety and tolerability, and the evidence from solid tumors that these drugs are potentially quite effective in a number of different cancers. We have seen an established role for pembrolizumab now clearly in Hodgkin's lymphoma. There are excellent data with pembrolizumab in a related disease, primary mediastinal diffuse large B-cell lymphoma, where checkpoint inhibitors such as pembrolizumab now have excellent single-agent activity, and there are now larger phase 2 studies that speak to that. Where checkpoint inhibitors have struggled is really beyond that in broader lymphoma populations, and we have unfortunately not seen a lot of activity with this class of agent in diffuse large cell lymphoma broadly, or in patients with other common indolent lymphomas, such as follicular lymphoma, though there are some data that in combination, these may represent useful approaches. That being said, I think we have some excitement because there are good signs of activity with these agents more broadly in other challenging lymphomas, such as T-cell lymphomas, including NK cell lymphomas, and there are now a number of trials evaluating these agents in that setting.